Good afternoon, everybody. I'd like to welcome you all to our next session of the APDR National Virtual Noon Conference Series. I'm Dr. Hart Beatty, the chair of the Education Committee for the APDR and Neuroradiology Fellowship Director at Boston Medical Center. Welcome to all of you. I'm so excited to have new and old friends speaking today on musculoskeletal imaging. We'll start with a couple housekeeping items. As you know, the lectures are being recorded and they'll be hosted on the APDR YouTube channel to view for free whenever. Also, your microphones are being muted as attendees to ensure optimal quality. And if you do have questions for our presenters today, we ask that you use the Q&A tool on the Zoom platform, and they will get back to you with answers to those questions. I'd like to introduce both of our really amazing speakers today for musculoskeletal. First speaker we're going to have today, there's a little switch in the schedule. We're going to have Dr. Gaviola speak first, instructor of radiology at Brigham Health, Harvard Medical School, and also the Radiology Residency Program Director. And a pleasure to have Dr. Mohamed Jarraya with us today, who just joined the faculty at Massachusetts General Hospital, Harvard School Medical School. And Dr. Gaviola is going to be speaking on pitfalls and shoulder arthrography, and then beyond the sacroiliac joints, vertebral involvement, and axial spondylarthritis. So thank you both to take the time out of your busy clinical workload to give talks. And without further ado, I would ask Dr. Gaviola to share his presentation with the group.
Pitfalls in shoulder arthrography. So we're going to use a case-based approach with a self-assessment questions for everybody to kind of see how their progress is going. So feel free to answer these on your own, and we'll share the answers at the end. I have no financial disclosures. And again, thank you to Dr. Beatty and the APDR for allowing me to speak today. So just to warm everybody's brains up a little bit, I've got two questions for you to think about as we progress through the day with the conference. So this is an image from a shoulder arthrogram, and the question is true, false. Fluoroscopic guided shoulder arthrogram shows a full thickness rotator cuff tendon tear. So take about 10 seconds to see if that's true or false. Okay, and we're going to contrast that with this next arthrogram. And to make it easy for you, I've kept the question the same. So true or false, fluoroscopic guided shoulder arthrogram shows a full thickness rotator cuff tendon tear. So hopefully by the end of this talk, you'll be able to answer these questions. So over the next 30 minutes or so, our goals and objectives are to demonstrate the different types of shoulder arthrography, review the clinical indications for why we do shoulder arthrography, and using an image-rich case-based format, illustrate the appearance of a normal arthrogram and some of the pitfalls you may encounter with both anterior and posterior approaches, and how we would correct these for continuous quality improvement and optimal diagnosis. So first of all, the types of shoulder arthrography. So the most common is going to be your conventional fluoroscopic guided arthrography, where under fluoroscopic guidance, you're going to insert a needle into the glenohumeral joint, inject contrast within the joint once you're intra-articular, and then demonstrate and opacify the joint under fluoroscopy. In most cases, patients will be sent for additional cross-sectional imaging. So they could go for a CT arthrography, in which case the contrast that we inject will be iodinated contrast only, and they'll show the bony and the soft tissue anatomy well. Alternatively, the patient can be sent for MR imaging, for MR arthrography, in which case both iodinated contrast and dilute gadolinium are injected, since the iodinated contrast will not show well on T1 weighted images on MR. So these are the three types that we'll do, and we'll go briefly thinking about how we approach these and why we do shoulder arthrography. So first of all, fluoroscopic arthrography, the main purpose of this is to really distend the joint. And what this does, it allows us to see the separation of soft tissue structures better. So recall under X-ray and fluoroscopy, there's really 5 densities that we see. And of all the soft tissues, all soft tissue looks the same, whether it's muscle or bone or cartilage. And in order for us to separate them out and improve the image contrast, we really need to add another density in there. And in this case, it's contrast. So here's a nice example where we're injecting contrast within the joint. We see the initial sliver of contrast, and then subsequently contrast opacification of the joint. And mag-up view, after we take the needle out, you can see that there's contrast, only a small sliver of that dark contrast outlining the humeral joint, glenohumeral joint, and then underneath that, opposing that, is that cortex of the humerus. And in between, you see that lucency here, and this goes to show you how nicely we can opacify and see the humeral head cartilage. And we would not have been able to see that without that contrast in the joint. And so there's a lot of beauty with introducing contrast in the joint and really resolving the soft tissues there. So the second is obviously contrast is going to enter into abnormalities within these soft tissue structures. So if we have torn tendons, labra, or ligaments, we'll be able to see contrast being imbibed in those areas. So here's another example where we have glenohumeral joint contrast, and here's normal on the left. And in this case, we see that there's extra contrast that's opacifying inferior to the axillary pouch. And this is also known as your humeral avulsion of the inferior glenohumeral ligament, otherwise known as a Hegel lesion. So with that defect in the inferior glenohumeral ligament, we'll see contrast going through those abnormal tears within the soft tissues. And then finally, demonstrating abnormal communication for the joints, and in particular for the glenohumeral joint. So the subacromial subdeltoid bursa is separated from the glenohumeral joint through the rotator cuff tendons. And in actuality, the glenohumeral joint roof is the rotator cuff tendons. So if you have an abnormality through the rotator cuff tendons, you'll see a communication between injected contrast in the glenohumeral joint and the subacromial subdeltoid bursa, as we see in this case here. So you'll see that there's contrast within the joint, but as you see in the normal example on the left, there shouldn't be any contrast at all in the subacromial region, given that there's intact tendons. And in this case, you see contrast going into the subacromial subdeltoid bursa, thus indicating that there's a full thickness rotator cuff tendon tear through which the contrast entered. And in addition to that, we also see contrast within the substance of a tendon itself in the rotator cuff, as in this case, where we have a delamination, in which case those fibers are all torn and contrast is being imbibed in those torn tendon fibers and causing the delamination and interstitial injury to the tendon itself. So just to show you, the patient went on for having an MRI, and this is the MRI correlate to that. So you see that there's contrast within the joint, contrast in the subacromial subdeltoid bursa, and then contrast within the substance of a tendon itself through the delamination injury. So these are all major reasons why we do shoulder arthrography, we really evaluate the soft tissues much better. So how do we decide whether the patient should just go for fluoroscopic versus MR or CT? So fluoroscopic arthrography has been the mainstay of rotator cuff tendon tear evaluation until the advent of cross-sectional MRI, which was non-invasive and shows the tendon anatomy much better. Now arthrography is really just done when MRI or even ultrasound now is demonstrated to be great for looking at the torn rotator cuff tendons. So in the absence of those contraindications, fluoroscopic arthrography becomes a mainstay. And it's obviously helpful for both diagnostic and therapeutic aspirations and injections when we deliver steroid medication for pain therapy to these areas, or if there's a suspected septic joint, in which case we would do arthrocentesis through fluoroscopy as well. So MR arthrography is helpful for distinguishing full thickness versus partial thickness cuff tears, which can sometimes be tough without contrast at routine MR, due to the fact that sometimes the fibers are pressed up against each other, and distension of the joint allows the contrast to imbibe in those areas. And it's also good for primary evaluation of the capsular and labral structures to look for labral pathology in the setting of instability, especially in young patients and elite athletes, where contrast will be imbibed in those labral tears. CT arthrography has been shown to be much more superior to MRI and MR arthrography for postoperative evaluation, particularly in patients who've had a total shoulder arthroplasty or postoperative cuff or labral tears, and especially evaluating loosening of implants, although ultrasound is demonstrated in most recent times to be equally as good. And then obviously when MRI or MRI is contraindicated, CT arthrography has been helpful as well. So you can see here in a case of preoperative evaluation with severe glenohumeral osteoarthritis and the full thickness rotator cuff tendon tear. So how do we decide versus CT versus MR? So Dr. Jarraya, our next speaker, wrote about this in 2016 and noted that both are equally good for slap tears, for full thickness rotator cuff tendon tear, and labral ligamentous complex injury. Where CT outperforms MR arthrography is really the evaluation of cartilage surface defects, particularly in preoperative evaluation, and obviously osseous defects, which can be more challenging under MR. So when we have preoperative glenoid bone stock evaluation or looking at engaging Hill-Sachs and bony Bankart lesions in patients with recurrent shoulder dislocations. CT is much more preferred. Where MR outperforms CT is really looking at intrasubstance tendinous injuries, as well as extra-articular tendinous injuries, where we have to look at other things such as the deltoid musculature or other nearby structures and biceps tendon injuries. So this is a nice good summary. You could read more about it in Dr. Jarraya's paper. So just a quick break in our first third of the talk, just for self-assessment here. Here's our first question that you can think about and think about the answers. So in which of the following clinical scenarios would a shoulder arthrography be indicated? So A, 25-year-old athlete with a history of recurrent shoulder dislocations. B, a 75-year-old with history of prior total shoulder arthroplasty with concern for cuff tear. C, 45-year-old with cardiac pacer evaluated for slap-type labral tear. Or C or D, 65-year-old with glenohumeral joint effusion and suspected septic arthritis. Or E, all of the above. So just in summary, all of the above would be appropriate here. We didn't specify whether it was fluoro, MR, or CT, but all of these would be good reasons for why a patient would be sent for shoulder arthrography. All right, so let's go on to the next part, is thinking about what a normal shoulder arthrogram should look like. So arthrography can be performed both from an anterior or a posterior approach. I would say the majority of patients will undergo an anterior approach, and that's the culture of most orthopedic surgeons, although posterior approaches have gained popularity with some surgeons when the risk of injuring anterior structures, such as the subscapularis or biceps tendon, is at risk. So for an anterior approach, this is good for evaluating posterior instability. For anterior approaches, you want the patient supine and external rotation, and you're going to end up getting a frontal view with the glenohumeral overlap here between the glenoid and humeral head. We're going to avoid injecting the labrum, which is at the joint line itself, so we're going to stay on the humeral side. And we generally have two approaches where you can either target the subscapularis approach, where you're going to basically advance the needle in the lower 1/3 of the humeral head, right at the overlap, and this would be the target there. Or the rotator interval approach, which is slightly up superior and is away from the subscap tendon, and this will be in the upper 1/3 of the humeral head, just to the lateral aspect of the glenoid and humerus overlap. So the most important part of any fluoroscopic injection is that initial first cc of contrast. So once you have the needle projecting into the joint and you're hitting the humeral head, you'll want to inject a few slivers of contrast just to document that you're in the joint. And this is the most specific sign that you are intra-articular, is this initial glenohumeral crescent of contrast. And that really shows you the outline that you're in the joint and outlines the humeral head right there. And it's important to document that in the first cc of injection, otherwise that can get obscured. And we'll see that in a few minutes. So once you distend the joint to about 12 cc's, 10 to 12 cc's are generally the volumes, you'll be able to see this nice shape of the joint contrast and where it's outlined. So we mentioned before, you can see the humeral head cartilage nicely. You can see a filling defect from the biceps tendon. You'll opacify the axillary pouch in the inferior glenohumeral ligaments. We'll see the subscapularis recess, which is this tongue-like projection inferior to the coracoid process. And then importantly, there's the relative lack of contrast in the subacromial space. Again, this is because the normal intact tendon should be sitting in there, and we don't want to see contrast in that area. Okay, so now that you know what a normal arthrogram looks like, let's run through a few cases and kind of troubleshoot and see what is happening with each case and how we can improve the quality of them and maybe demonstrate some pathology. So here's our first case. We'll see that this patient is undergoing a rotator interval approach. We're up the upper 1/3 of the humerus on the humeral side from the overlap between the glenoid and humerus. We've injected a cc of contrast, demonstrated we're intra-articular, because now we're starting to opacify that cartilage, so we know we're intra-articular. And as we inject, we fluoro, and we'll start to notice that there's contrast in the axillary pouch. But in addition to that, we're seeing opacification of something that we shouldn't be seeing. It's this band-like triangular area of contrast. And on our post images, we'll notice that there's a filling defect here with linear band-like striations. So what exactly is this? So this is not part of the joint. We wouldn't expect to see it here. And when we send the patient for MRI, you can see that in the coronal images, we're actually contrast opacifying the subscapularis tendon. right here, and that's what demonstrates that filling defect. So this actually becomes our first pitfall when we do these through the subscapularis approaches. We can actually inject the muscle itself. And obviously we don't want to do that, especially if you're concerned about subscapularis injury. So this is often the time where a subscapularis approach can be a little bit challenging with the increased tensile forces of the tendon itself, making it sound like you're intra-articular. So in this case, the needle was partially in and partially out. So how do we avoid that pitfall? So essentially, the bottom line is the needle is too superficial when we did the subscapularis approach. In this case, the needle could have migrated there. I know, so what we need to do is basically advance the needle to obtain the intra-articular injection. So your needle is too superficial, and the only way to do that is make sure that we're a little bit deeper than we need to and inject. So great. All right, so that's good. So moving on to case 2. So again, we're now injecting the joint here, and we'll notice we injected our first CC. We see that glenohumeral crescent in there. And as we opacified the joint a little bit, we're starting to see the margins that we expect for the joint. But something's a little bit weird in the way that the joint is being opacified. So clearly, initially, we saw that there was severe glenohumeral osteoarthritis. The cartilage space was narrowed, and there was hypertrophic lipping, and there's remodeling of the bone. So this is a nice example of advanced glenohumeral change. But you'll notice that the contrast does not fill the joint uniformly, and we should see nice and smooth margins. So you see that there is irregularity of the joint space. There's multiple filling defects here. That's either due to synovitis or multiple bodies. So obviously that shows the pathology really nicely. But in addition to that, we're also seeing this wispy, curvilinear areas of opacification in the region of the axillary pouch. And it's extending on into the axillary soft tissues, and there's maybe a little pooling here in the axilla. So what exactly does this represent? So the patient went on to have the CT arthrogram. So in this case, as we mentioned, this patient had a CT arthrogram to evaluate for preoperative evaluation for a total shoulder arthroplasty, in addition to having postoperative changes from rotator cuff tendon tear. And again, we see the findings of the advanced OA. But you'll see that some of that contrast is actually layering out into the vessels in the axillary pouch and into one of the lymph nodes down here. So this is a nice example of lymphovascular uptake where the needle actually went into the bone. So you'll notice the bone marrow actually is a direct connection to the vascular system, reticular endothelial system. So when you're intraosseous, that's actually going to be systemic. So it's something to really be careful if your needle is essentially a second pitfall, which is you're too deep. This can often be manifested as pain when the patient, when you start injecting because there's increasing intraosseous pressure. So sometimes there's extensive subchondral marrow edema and the bone is going to be very soft in these patients, so it can be easily to penetrate deeper. So obviously in these cases, you want to gently retract the needle so from your intraosseous location and prevent that uptake from the synovitis and lymphovascular uptake. Okay, moving on to case 3. So in this case, we're doing an injection here. Your needle is in the joint, and it's demonstrating a little bit of that curvilinear glenohumeral crescent that we would expect to be intra-articular. And then as we opacify the joint, we get nice smooth margins. We get the expected anatomy that we see. But in addition, we're seeing a little bit of this wispy contrast in that labral region here. So the patient went on to have the MRI, and this was a concern for a slap-type labral injury. And you'll notice that in the superior labrum, it doesn't look uniformly homogeneous in terms of its signal, but instead there's uptake of contrast or bright signal within it on the T1 here. And as we propagate out posteriorly, superiorly, you'll see that there's propagation of the signal. So this raised a concern that there was a superior labral tear from anterior to posterior or a slap-type tear. And the question is that really true? So if we look back on our arthrogram here, this is a really important part to really be mindful of your needle tip as you do your arthrogram. And you'll notice here that the tip actually migrated off the humeral head and is now within the labral soft tissues. So this could actually be iatrogenic in terms of its pathology. So this is really important to recognize that you don't inject when you're in there. Otherwise, you're going to create a slap-type tear or propagate a slap-type tear. So this is another pitfall here where your needle is injecting into the biceps labral angle because it's migrated off the humeral head. So recognize that the humeral head is a spherical curved surface. So even though you feel like you're on humeral head, if you're not being careful as you inject, the needle can actually slip into the joint, into the soft tissues. So what's important to recognize here is the needle migrated off, and it's important to repeat the injection away from the humeral joint line. So move the needle off and then reposition. So ideally, remember, this is where your needle tip needs to be. It's on the humeral side and not within free floating in the soft tissues. All right, so moving on to case 4 here. So this is a subscap approach that we're doing, and we're injecting contrast within it. And you'll notice the needle tip is projected over the humeral head, and we're opacifying the joint, or what it's expected to be the joint, and then contrast is extending into what looks like the subacromial subdeltoid bursa. So the patient, so the question is this a full thickness rotator cuff tendon tear? So the patient went on to have the MR arthrogram, and we'll see that there is contrast within the subacromial subdeltoid bursa, but most notably, recognize the absence of contrast actually within the joint itself. So you can see that the humeral head and glenoid cartilage are opposed to one another. There's not a single ion of contrast outlining the joint. So was this tear to begin with? So as we see, there was contrast in subacromial subdeltoid bursa. And on our sagittal images here, you'll notice that anterior to the subscapularis muscle, which is sitting right here, there is contrast being opacified in the subacromial, in the subcoracoid bursa. And notice that these two are connected. So these are connecting structures, the bursa are connected. And if you're not deep enough, it's hard to tell whether you're actually in the joint or not at fluoroscopy. So on the fluoroscopy, you will notice that this is actually all opacified in the subcoracoid bursa. And on the lateral view of our fluoroscopy here, you'll notice that it's all connecting to the subacromial subdeltoid bursa, as we saw in the MR here. So this is an important pitfall to recognize, because this, rather than a glenohumeral injection, this was actually a subcoracoid bursal injection, and this is extra-articular instead of the glenohumeral joint. So this is an important pitfall to recognize, especially with anterior subscap approaches, because you may feel like you're in the subscap because of the tensity of the joint itself, but as you inject, none of it's actually going into articular. So this is the importance of looking for that glenohumeral crescent at that first cc of injection here to make sure that you're intra-articular to begin with. And as you'll notice in our case, there were no initial images to demonstrate that, and there's a complete absence of that crescent. So in this case, it's important to recognize that you don't want too much of that contrast in there to be obscuring the joint, and you want to make sure you document that initial contrast. And again, on the lateral view, you'll see that you should have axillary pouch distension, and on the lateral view in our patient, there was none of that. So that all demonstrated that it was not intra-articular to begin with. So again, this is an important pitfall to recognize. In this case, the needle is too superficial, and you need to advance the needle deeper into the glenohumeral joint. And again, this is the point to recognize that the bursae are continuous, but not with the joint. And inadvertently, we did diagnose this patient with a high-grade partial thickness bursal surface tear, so you can see that there's actually bursal surface contrast within this tendon here, which may not have been seen inadvertently on a glenohumeral joint injection. So one way to avoid this in considering a posterior approach. So for posterior approach, it's done again to evaluate for anterior instability. And in these cases, the patient is laying prone, slightly oblique in a semi-decubitus view, and the view that you get is actually a Grashy view rather than a frontal view, so you can see the joint line better. And again, it's important to not inject at the joint line because you want to avoid the labrum, and instead you want to target the humeral head. And there's a lot of variability on where to target, but most people will target medial to lower 1/3 of the humeral head on the humeral side. So eventually, you'll again see that glenohumeral crescent, and then you should opacify the joint similarly where you get the humeral head, biceps tendon, axillary pouch, and in some patients, the subscap recess will be variable in terms of its distension. You may not see as much from a posterior approach. So moving on to case 5. So we did a posterior approach here. Again, we've post-surgical change. We see there's the glenohumeral crescent here, so we're intra-articular. And as we inject contrast, again, we're seeing this linear sliver of contrast that doesn't look like it's conforming to the joint space, and a lot of it is seeing more posteriorly here. So again, this is abnormal. Patient went on to have their CT arthrogram. You'll see that that actual contrast is conforming to the muscle. And then this is another example of intramuscular injection, and this time, because you did a posterior approach, this is in the infraspinatus rather than the subscapularis. So this is another pitfall where your needle is too superficial or shallow, and you need to just advance the needle to obtain that intra-articular injection. All right, so our last case here to look at, so this is case 6. So again, a posterior approach we're attempting. Notice the Grashy view is not ideal. You still see some overlap here, and it doesn't really give you a nice viewpoint, but this is the best that the patient can tolerate. Oftentimes, that's the challenge with the posterior approach, is the ability of the patient to lay in that prone position, oblique. In this case, the needle was advanced until the trainee actually hit os, and contrast was injected. The trainee noted at the time, telling me that they felt that the bone was pretty superficial. So as they injected contrast, you'll see that the contrast is not the glenohumeral crescent, but instead looking like it's linear. So maybe again a muscle. But recognize that when they hit the bone here, they thought they were hitting humeral head. But instead, if we look at here, that there's actually another bone overlapping this, and you'll recognize that this is the acromion that's actually overlapping here, and that the needle is actually hitting the acromion itself. So this is actually extra-articular also, due to the fact that the acromion was injected, and thus far the deltoid musculature took that uptake. And again, this last pitfall that we see. So in this case, the needle needed to be moved more inferior and medial to advance the humeral head, to get to the humeral head right in this area here. So again, the patient was, couldn't tolerate the optimal positioning, but so then we just moved the needle. And again, after we do that, we get the initial sliver of contrast, and that shows the intra-articular location here. And again, we see that on the Saggery format on the CT, that deltoid muscle has that uptake, but after repositioning, we got intra-articular here. So on the lateral view, we'll see what that needle ended up. And again, the needle was approaching here, more superficial for the acromion. All right. So to conclude, so let's finish up some SAM questions here. So which of the following is not usually identified on normal shoulder arthrogram? So axillary pouch, biceps tendon sheath, cartilage of the humeral head, subcoracoid bursa, or the subscap recess. So of these, I mean, the other question would be which of these is part of the shoulder arthrogram? So of these, the subcoracoid bursa is not. So a normal shoulder arthrogram, we should be able to see the axillary pouch, the biceps tendon sheath, the cartilage of the humeral head, and the subscap recess. Again, the bursae, unless there's a torn tendon, rotator cuff tendon, we shouldn't be able to see the bursae. And next question is, contrast injection into which of the following is definitive and intra-articular glenohumeral joint injection? So subscap recess, subscapularis muscle, subcoracoid bursa, subacromial subdeltoid bursa, or acromial injection of the deltoid muscle. So of these, the only one that's intra-articular is the subscap recess. Again, that's the tongue-like projection underneath the coracoid. The rest are extra-articular. So our take-home points for today. So here's our summary of the pitfalls and the solution. So we saw a case of intramuscular injection, both the subscap and infraspinatus. So in this case, the needle was too shallow. You were intramuscular, and the technique there is to advance the needle. We saw a case of lymphovascular uptake from the needle being too deep, intraosseous, and the solution there is to retract the needle. We saw a case of biceps labral injection where the needle migrated off the humeral head. And again, in that case, you want to move it back to the humeral head. We saw a case of subcoracoid injection where it was subscap approach where the needle was too shallow in the bursa. So you want to advance the needle a little bit deeper or consider a posterior approach. And we saw a case of acromial injection as the deltoid from the needle being too shallow in the posterior approach where we were intramuscular. And again, you want to move the needle inferior and medial to that. So hopefully we were able to achieve our goals and objectives here to demonstrate the different types of shoulder arthrography with the indications, what a normal arthrogram looks like, the different pitfalls we just mentioned, and how to improve these for continuous quality improvement. So just to finish up our pre-lecture evaluation, so true or false, full thickness rotator cuff. So full fluoroscopic guided shoulder arthrogram shows a full thickness rotator cuff tendon tear. This is true. This was the one demonstrating delamination into the fibers. And next case was this one. which was false, and this was a actual bursogram rather than a glenohumeral joint injection. So this actually showed a subcoracoid bursal injection. So thank you so much for your time, and I'm happy to take questions or else email me. You can see my contact information there. And thank you for the opportunity again to speak to all of you. Hopefully you learned some arthrography and some anatomy for your core exam this coming spring.
Dr. Gaviola, thank you so much. Really wonderful talk, great cases and beautifully laid out. I would like to invite Dr. Jarraya to give his presentation, please. Thank you, Dr. Jarraya.
So I'm talking today about the vertebral involvement of axial spondyloarthritis. And the reason why I'm not going to focus at all on the sacroiliac joints is actually two reasons. First, we often read spinal MRIs without knowledge of what's going on in the sacroiliac joints. And in these cases, it's important to know the pattern of involvement of vertebra and spondyloarthritis. And the second reason, which is even more important, is that sometimes in early disease in spondyloarthritis, we can have isolated vertebral involvement without sacroiliac joint disease. For instance, there is this paper that was published last month that showed, that was actually focusing on studying the prevalence of spinal and sacroiliac involvement in spondyloarthritis, and it showed that 1 in 4 patients had thoracic spine bone marrow edema without sacroiliac joint disease, and for that the authors concluded that isolated spinal involvement is actually relevant for diagnosis. So we will start with a quiz. This is a 45-year-old male, and I'm going to ask you what's different between 2011 and 2015. So if you look at 2011, you can see that the costovertebral and costotransverse joints here are normal. You see nice subchondral bone, regular. The facet joints are mostly normal. And then in 2015, we can see that there is irregular appearance of the subchondral bone, joint space narrowing here in the costovertebral and costotransverse joints. And if you look at the facet joint osteoarthritis, it's even more conspicuous. You can see multiple levels of ankylosis and severe joint space narrowing. Looking at the same patient, but now for the sacroiliac joints, we can see the progression of disease between 2011 and 2015, erosions and more fuzzy appearance of the subchondral bone with cystic changes, sclerosis along the subchondral bone. So this patient had spondylarthropathy. The patient also had an MRI for low back pain. And although this is faint, you could see here there are some corner edema of the anterior corners of the upper lumbar vertebral bodies. In addition, you can see here posterior ligamentous edema and lower lumbar facet joint synovitis/capsulitis here. So spondyloarthritis is also called spondyloenthesoarthritis because it involves the vertebrae, the enthesis, and the joints. These are actually a group of diseases that have in common one thing, that they are negative for rheumatoid factor. So these are seronegative inflammatory joint diseases. So in addition to psoriatic and reactive arthritis, in addition to spondyloarthritis associated with inflammatory bowel disease and undifferentiated spondyloarthritis, the most common of these entities is ankylosing spondylitis, which we will focus on today. So ankylosing spondylitis, the prevalence is between 0.2 and 2%. We know that the axial involvement is predominant, specifically the spine and the sacroiliac joints. Historically, the first-line treatment was NSAIDs, and then with the advent of TNF inhibitors, this has completely revolutionized disease management. TNF blocking drugs are to be used in patients with non-radiographic disease, and to be very specific, I mean pre-radiographic disease before the apparition of the first radiographic signs, and in patients with severe symptoms and MR signs of inflammations. In 2009, the ASS, which stands for the Assessment of Spondyloarthritis International Society, had published criteria that included for the first time MR imaging as a diagnostic criteria for spondyloarthritis. So this is the paper, and it's an MR definition of an active sacroiliitis for these patients. So we said that there are 3 entities, basically enthesitis, joints, and vertebral involvement. So for the enthesitis, these are inflammation of the fibrocartilage at the insertion of ligaments or tendons. In this drawing, you can see the anterior longitudinal and posterior longitudinal ligaments. we can also see the interspinous ligaments and supraspinous ligaments. Any attachment of these ligaments are the entheses that we're talking about, and the inflammation at these places will give us edema. In addition to the enthesis, synovial joints can be involved, and in the spine, we often think of synovial joints. We often think of facet joints first, but in truth, costovertebral and costotransverse joints are even more relevant in patients with spondyloarthritis. And the reason is that these are driven for this chest expansion during breathing and coughing, and involvement of these joints can give severe back pain and also limited chest expansion during breathing. Also, inflammation in the posterior synovial joint may mimic pleuritic pain. So this is what a normal spine looks like. In the preradiographic disease, there is inflammation, and the inflammation will involve the synovial joints, as you see here, the enthesis. Here you can see the posterior and anterior longitudinal ligaments. The inflammation could be centered about a intervertebral disc along the end plates, and that's an aseptic discitis, inflammatory discitis, or involve the vertebral body, and that's the spondylitis. Later on, after the inflammatory phase, there is a radiographic, some radiographic findings because of bone proliferation, and with time, these radiographic findings will lead to ankylosis. You can see here facet joint ankylosis and bridging syndesmophytes, which will give the bamboo spine appearance. So imaging modalities, we will talk about conventional radiographs. To be clear, radiographs only detect the chronic bony changes. So for example, here you can see this shiny corner sign here, which is a triangular area of sclerosis in the superior corner of the vertebral body. To be clear, shiny corner is a radiographic sign, not to be confused with Romanes sign, which is an anterior corner edema and MRI. Another radiographic findings is the reactive bony erosions. And then syndesmophytes, which are a mineralization along the anterior longitudinal ligaments here, as you can see. You can see also the demineralization of the spine. The discovertebral pseudarthrosis, also known as Anderson lesion, which is often associated with insufficiency fracture. So Anderson lesion is originally a radiographic finding first described in 1937, and is often associated with insufficiency fracture. Now I know that in the imaging literature, sometimes Anderson lesion refers to Anderson discitis. And this paper, which is a review from 2009, actually has a very nice discussion about the etiology of Anderson lesion. There are basically two pathways, either through inflammation along the disc or a trauma in a patient with osteopenia and ankylosis. Both these pathways will lead to the same result, which is a discovertebral pseudarthrosis, often associated with insufficiency fracture of the posterior elements. So because of the TNF inhibitor use, oftentimes there is a slow radiographic progression in patients that are on TNF inhibitors. For instance, this patient is a 38-year-old man. He has a 25-year history of ankylosing spondylitis. He is being treated with TNF inhibitors, and he presents for worsening of back pain, both in his thoracic and lumbar spine. And he has severe pain. He was not able to sleep. You can see here the radiographs. We can see that there is some ankylosis of the sacroiliac joints, clear disease. But then if you look at the vertebral bodies, both in the vertebral, in the lumbar and thoracic spine, you can't see a single syndesmophyte or a shiny corner or erosion. And the reason for that is that this patient has been on TNF inhibitors. And there is a lot of literature about that. For example, this paper was released online yesterday. It was first presented in the ACR, the American College of Rheumatology, in 2019, that makes the exact point that patients that are on TNF inhibitors have a slower radiographic progression. And that's why patients need to be started on these TNF inhibitors before the first syndesmophyte and before the first focal fatty deposition on MRI. Other imaging modalities, so computed tomography, it allows a better depiction of bony structural changes. However, it's not often used because it has a much higher radiation exposure. So it's much more rarely used. In this example, this is the same example that I showed earlier, this disco vertebral pseudoarthrosis with insufficiency fracture. It's much better seen on CT, as well as the fracture of the posterior elements. And also CT is much more helpful to identify disease of the posterior elements, specifically ankylosis. Bone scintigraphy has also been used to detect foci of active inflammation. However, it has limited specificity, as we know, and it has high radiation exposure. So it has now limited indication, specifically because of the advent of MRI. For MRI, so MRI is now probably it's the gold standard for the diagnosis and assessment of patients with spondyloarthritis. Usually, it is recommended to use an MRI that is contrast enhanced. The sagittal T1 images are good to detect chronic bony changes. And in addition to the usual sequences are sagittal FATSAT and sagittal T1, it is recommended to use axial FATSAT T2 in order to detect better the inflammation in the posterior elements. So as I said, MRI is now the gold standard for early diagnosis and monitoring of inflammatory lesions and spondyloarthritis. So now we will go through active inflammation in the vertebral body. Bone marrow edema can involve the corners, the anterior corners and the posterior corners, and these are the secondary to enthesitis of the anterior and posterior longitudinal ligaments. Romanus lesion when they involve the anterior corners. These could be, these are stir hyperintense and T1 hypointense with possible enhancement after contrast enhancement. When the signal abnormalities are along the end plate, these are the aseptic discitis. This is a nice example of that. Same signal characteristics and variable contrast enhancement after injection. And this is also described as inflammatory Anderson lesion. Bone marrow edema can also be seen in the posterior elements, in this case in the pedicle, posterior rib. The synovitis also can be seen in costovertebral joint as seen here, and the facet joint. We could see effusion of the facet joints and ligamentous edema here in the interspinous ligament. So the important bit in this slide is that posterior involvement may be isolated. So it's important to actually specifically look at the posterior elements. And this is much better evaluated with axial or coronal images or fluid sensitive, so T2 FATSAT. If axial and coronal images are not available, it is recommended to be very careful as interpreting the sagittal images. And costovertebral and costotransverse joints are very helpful to understand why a patient has pain or like difficulty breathing. So now to go back to the same patient that I showed earlier, 38-year-old male with a long-standing history of AS. This patient has severe pain, normal x-rays, besides that he had sacroiliac joint ankylosis. This MRI was read first as normal, and the patient had severe pain. And if you look actually on these sagittal images, you can see faint but obvious corner edema of the posterior vertebral bodies. And this also involves here multiple pedicles and the expected location of the costotransverse joints. This is to say that posterior element edema can be isolated in these cases, and it's very important, especially when we don't have axial T2 FATSAT, to look very carefully at the sagittal stir. In addition, for enthesitis, it has been shown that gadolinium images increase the sensitivity for these lesions. So this paper is from Skeletal Radiology 2016, and it shows, for example, in this patient that a stereo image is totally normal, and then post-contrast you see multi-level enhancement of the interspinous ligament. One of these patients that I'm going to present makes the same point. We see here an isolated bone marrow edema of T10. And then after contrast enhancement, what we see is a more extensive inflammatory regions that involve not only the posterior element of T10, but also multiple interspinous ligaments at the lumbar spine level, and also facet joint osteoarthritis in the thoracic spine. In addition, MRI is also helpful to detect chronic bony changes. For example, here, erosions, fatty deposition, and syndesmophytes. And as I said earlier, patients that are treated with TNF inhibitors before apparition, before these fatty deposition syndesmophytes, they show slower rate of progression of radiographic disease. So the clinical relevance of this is that vertebral involvement may be isolated in early disease without sacroiliac arthritis. And in addition, there is now a trend to actually map inflammatory lesions in patients with spondyloarthritis to assess the efficacy of DMOD, with, in this case, the TNF inhibitors. Posterior inflammation may result in pseudopleuretic pain, and it may also result in altered chest expansion, which in turn would result in restrictive pulmonary syndrome. So it's very important to keep in mind to actually attentively look for posterior spinal inflammation. Now, this patient is a 41-year-old male. He has a 20-year history of ankylosing spondylitis. Patient has active disease with chronic inflammatory back pain and shortness of breath. There was a restrictive syndrome that was diagnosed on pulmonary function test, and a lung CT is performed. And we can see here bilateral apical fibrosis. So apical lung fibrosis is a rare lung manifestation of ankylosing spondylarthritis. It is even more rare now with the advent of DMOD. And it's hypothesized that apical lung fibrosis is secondary to altered chest expansion from posterior spinal involvement. There are other hypotheses that that think that this could be actually an inflammatory also mediation, but the main hypothesis is basically posterior joint involvement and restricted chest expansion. Now we talk about a differential diagnosis. The main differential diagnosis here is Sappho syndrome. This patient is a 33-year-old male. He has long-standing low back pain, and you can see here these nice hemispherically shaped stirred hyperintensities along the end plates, kind of eccentric, very much low T1 signal. And then the bone scan shows increased uptake in the anterior chest wall. And the SPECT images show the same thing, osteitis of the sternocostoclavicular joint with increased uptake. So this is a Sappho syndrome. So Sappho includes 2 cutaneous components and 3 musculoskeletal components. The cutaneous lesions are the pustulosis and acne, and the musculoskeletal lesions are osteitis, hyperostosis, and synovitis. So there is some similarity with spondyloarthritis with musculoskeletal and cutaneous involvement. However, the etiopathogenesis for Sappho is unknown. There's a thought that Propionobacterium acnes can play a role in the genesis of this disease. And the most common site of involvement of Sappho is the anterior chest wall, specifically sternocostoclavicular hyperostosis. Now, the vertebral involvement in Sappho specifically happens in 1 in 3 patients, and it's spondylitis and discitis. There is a controversy whether SAPHO is actually a subtype of seronegative spondyloarthropathy because the vertebral involvement can look like a spondyloarthritis. However, now there is more and more evidence that SAPHO is more of a primitive inflammatory osteitis rather than a seronegative arthritis. Vertebral involvement in SAPHO is variable, and it includes some features that are similar to spondyloarthritis, as I just said. So SAPHO is a limiting, usually self-limiting condition, while spondyloarthropathy is progressive. Both entities have in common the corner and marginal edema that leads to erosion and osteosclerosis. Both entities also have in common the disc space and sacroiliac joint inflammation. However, what's different between SAPHO and spondyloarthritis is the early chest wall involvement, sternoclavicular hyperostosis, and this is more, this appears more late in spondyloarthritis. The other difference is the prevertebral soft tissue thickening that is never reported in spondyloarthropathy. So for example, now this patient has low back pain. The findings are the following. We can see there is some bone marrow edema along the end plate that is in the exact same position as an osteosclerosis here, associated with some anterior erosions. And this patient has also bilateral sacroiliitis. So what we have is spondylitis with bone marrow edema at the site of bone sclerosis, along with sacroiliac involvement, and this is highly suggestive of SAPHO. Other differential diagnosis, degenerative disc disease, the classic inflammatory hemorrhagic type 1 end plate change. You can see some irregular end plates, bone marrow edema in the setting of degenerative disease, but no vertebral corner edema in this case. Scheuermann's disease, when the end plate edema is centered around Schmorl's node and involve multiple level. However, there is no involvement of the vertebral corners as well. And last, septic spondylodiscitis. And in this case, you have more signs of phlegmon, abscess, soft tissue thickening along the anterior soft tissues, and even epidural extension, and obviously end plate destruction and irregularity. So the key teaching points is, first thing, vertebral involvement can happen in a setting without sacroiliac joint involvement. And second thing, posterior elements can also be involved in isolation without involvement of the anterior vertebral body. Be careful about the costovertebral and costotransverse joints, especially if you do not have axial T2 fat sat or contrast enhanced images. These can explain severe back pain. Look specifically for the thoracic spine. Also, contrast can be very helpful in finding additional enthesitis that are not seen in STIR. And I know that usually in MSK, we think of STIR, anything that is bright in STIR should enhance on T1 and vice versa. But in this case, gadolinium is actually superior to STIR for this. And then SAPHO can show similar appearance, vertebral involvement. However, these could be distinguished by the presence of prevertebral soft tissue edema and sternocostoclavicular hyperostosis. These are the references, and a special thanks for everyone who helped collecting the cases. So on that, I'm happy to take questions if there are any.
Thank you so much, Dr. Jarraya. I mean, really, really two wonderful talks, beautifully illustrative cases, and we thank you for that. Thank you so much, everybody. We will join you on Thursday, where our next session will be on neuroimaging. And thanks again to both of our presenters today for two really, really wonderful talks. Be well.